So, hello and welcome everybody to today's Drug Hunter Flash Talk. I'm your host, Dennis Koester, and we will be talking about designing selective SIK2 inhibitors for dual anti-inflammatory and pro-repair effects in inflammatory and autoimmune diseases with Peter Tummino today. So, good morning again, Peter.
Great to be with you.
And now, without further ado, I want to introduce our guest, Peter. So Peter Tummino is the president of research and development at Nimbus Therapeutics, where he leads the discovery of non-clinical and clinical groups as well. Since joining Nimbus as the chief scientific officer in 2019, he has been a part of that leadership team. In his time at Nimbus, the company has successfully progressed the TYK2 inhibitor NDI-4858 through phase 2 trials for psoriasis and other immunology indications, have advanced the HPK1 inhibitor NDI-101150 through phase 1b trials in solid tumors, and initiated for phase 1 trials for the Werner helicase inhibitor NDI-219216 in MSI-high solid tumors. Peter brings over 30 years of experience in drug discovery across a range of different therapeutic areas. Prior to his time at Nimbus, he served as the vice president, global head of lead discovery at Janssen Pharmaceuticals, leading the global discovery operations across multiple therapeutic areas. At GlaxoSmithKline, he held leadership roles, including the head of biology for cancer epigenetics discovery, progressing first-in-class epigenetic agents into oncology clinical trials. His contributions at GSK included the discovery and progression of several clinical candidates, including the approved oncology drugs dabrafenib, a BRAF inhibitor, and trametinib, a MEK inhibitor, as well as daprodustat for chronic kidney disease, a HIF-PHD inhibitor. Earlier, he held scientific positions of increasing responsibility at Warner Lambert Park Davis, AstraZeneca, and Millennium Pharmaceuticals. Peter has published 85 peer-reviewed journal articles with over 15,000 citations. Peter earned his bachelor's in chemistry from the University of Massachusetts and his PhD from the Department of Biological Chemistry at the University of Michigan, completing postdoctoral research at Warner Lambert Park Davis. Peter, it's such an honor to have you here today, and welcome again.
Dennis, thanks. That was a great intro. I appreciate it. It's great to be here. Looking forward to the hour.
Amazing. And yeah, in the good old drug hunter tradition, we'd love to learn a little bit more about you. So we'd love to ask some, questions. And the first question would be, what inspired you, Peter, to start a career in drug discovery?
I started even going into undergrad, where I got a degree in chemistry, with an expectation that I just preferred applied science. And that's probably in my personality. I really wanted to have something where I could see an impact of the work being done. And so I did that as an undergrad. I probably didn't know what drug discovery was very much. I don't know that undergrads do. Went to grad schools and said I wanted to do drug discovery. Honestly, that's not very well received. I'm not sure that's actually the right thing to say in a grad school interview. Got my degree in biochemistry and did a postdoc at Warner Lambert, and it was on anti-HIV compounds. And then I was completely hooked because of the relevance of those compounds for our society at the time. And people were so desperate to get good antivirals for HIV. I knew this is what I wanted to do. I was super excited and have been excited since then to pursue different areas. But that was it. That's what hooked me.
I love that. Yeah, I love HIV compounds as well, as people know. My favorite molecule, lenacapavir. What's your favorite molecule, Peter, and why?
Dennis, I'm going to give you two because I'll give you the old school one, and I mentioned this to you. And I worked on HIV protease, and the molecule that I really loved came from Patrick Lamb when he published in Science, DuPont Merck's cyclic urea non-peptide inhibitor of HIV protease. Beautiful molecule, took a very different non-peptide solution back then, structure-based drug design back 32 years ago, and a real big success. Never made it to the market, but a real step forward. So that's one. And let's come modern day and mention one that everybody knows, but we have to all give a shout out for the KRAS inhibitors. So it is Amgen and Mirati and now RevMed and at least a half dozen other companies, they've succeeded. I've been in the business long enough to know this has been on the list, KRAS as a target, and no one succeeded for a long time. We have made that leap. And so a big shout out to those groups. I think we all saw the recent news, phase 3 results from RevMed doubling survival for late stage pancreatic patients. So super excited. I have to mention both of them. So I think we all congratulate them for that one.
Amazing. I love that. Yeah. Thank you for sharing that. And yeah, what are you most excited about in drug discovery today, Peter?
It really, so my area is small molecule, and I think, of course, I think about that a lot. And it even relates to what I mentioned, the specific of KRAS. It's that small molecule drug discovery is more capable than it has been 10 and 20 years ago. I wonder if folks in the field, because they're so close to it, they don't take a step back and realize how much more powerful small molecule drug discovery has gotten, the kind of targets it's taken on that could never have been done before. I remember 15 years ago, we used to use the word undruggable a lot, and people just don't say that nearly as much. Certainly, there are things that are very hard to approach, but it's gotten much, much better. And so I think that's a real pathway to new medicines that are going to help people. It's exciting.
I love that. Yeah, I definitely share that. I think people have used now the new word unassayable, like with the advancement of our tools. Like if you can't assay it, then you can't drug it. But I
I'll
think
question whether that's true. I like to use the word unprecedented, which only means we haven't done it yet.
I love that one.
Yeah.
Sounds good. Well, Peter, if you could go back to the beginning of your career and give yourself some career advice, what would you tell your younger self?
I do get questions on occasions for those people closer to the beginning of their career. And that if you're in industrial drug discovery, I mean, the one piece of advice I would give is to try to keep in mind what the North Star is. And for me, it's exactly what we just said, which is developing new medicines. There's many, many other activities and things going on in companies that are worthwhile, but you can kind of lose your focus. And if you are seeking that rewarding career to make a difference, it's always good to, in the back of your mind, saying, is this going to progress towards a molecule that's going to help somebody? If you can keep that in mind, it's really very helpful as you make decisions moving through your career.
Yeah. Now, I think that's it's very motivating. We live in or we work in a very rewarding industry, right? There can't be anything more purposeful than helping people be healthy through your job, right? I love that.
Yeah,
Amazing.
absolutely.
Yeah. And then last but not least, what do you most like about Drug Hunter?
Ah, again, a two-part answer. The surface answer, and it's really important, is the concise nature to get information. It starts with chemists, right? You guys show molecules, but it really does get everybody in drug discovery. It summarizes it so well that everybody gets this sense of what's going on. That's part one, but I actually think there's something deeper about Drug Hunter that's worth mentioning. Those of us in the industry know there's a level of competition, and sometimes we think of each other as competitors. It's really a minor part. We're all trying to do the same thing, which is to make better medicines. And I think Drug Hunter gives us the chance to celebrate successes and really make us remember that there's a community here all trying to do the same thing. And so I think that's really the best part of it.
Amazing. I love that. Yeah. Thank you so much for sharing that.
Yeah.
Yeah. And Peter, before we get started with your talk, I want to show people a new feature that we've launched just this week, actually. That is our new molecule search that you can find here on top. And what it does, it combines the structure search with search of targets. So you can now basically search chemistry in the context of biology. And that's very powerful in many different ways. You can, for example, use this in design meetings. So I want to give like a brief example. So if you, for example, are interested in hydrozones in drug discovery, like where have hydrozones been used, you can just draw this in the search box here, hit search structure. And what you'll find is how the industry has used hydrozones here, for example, in cyclic context and this pan-phosphate transporter inhibitor, or in a linear context here in this PRMT5 inhibitor. And you can flip through the different data sets. So if you're interested in only seeing FDA-approved drugs, you can toggle this one. If you only want to see modern clinical candidates, you can toggle here. And we're seeing those KRAS inhibitors that Peter mentioned earlier, daraxonrasib and others. If you want to see disclosures from conferences and the literature, you can toggle here. And you can also look at drug hunter molecules as well. What's very powerful as well, you can plot now different functions. You can hover here as well, see each molecule, bring it to the top if you want to further analyze it. If you want to see like how has the LogD, for example, in FDA-approved drugs or in hydrazone-containing drugs developed over time, you can see that very easily and answer very complex data questions in seconds now. What you can also do, you can type in a target here. So for example, if you're interested in PARP inhibitors that contain hydrazones, you can just type in PARP here, and you can trigger different searches from here. So you can directly go to a drug hunter search on PAMI-PARP, you can go to PubMed search, you can go to the literature, and you can even go into 3D as well. So you can click right here and be transferred right to the PDB, where you can immediately go to the structure and look into how this hydrazone binds 3D to your target of interest right here. So this is just a brief demo. I want to let you know that we do demos for companies almost daily, and we can tailor the demo to your company. And our customers typically span single-person biotech founders to the largest pharma companies in the world. And we support a range of broad functions in pharma with a growing membership from biology, DMPK, and even competitive intelligence, business development, and medical affairs. So if you're interested in a demo for your company, please indicate so after the flash talk or send us an email at info@drughunter.com. And with that, I will just hand it over to Peter now. We're very excited for your presentation on those SIK2 selective inhibitors. The stage is yours, Peter.
Thanks so much for everybody who's joining. I saw the numbers online. I'm looking forward to questions and discussions at the end. Thanks for joining. So I'm going to talk about Nimbus's program to develop selective SIK2 inhibitors for inflammatory and autoimmune diseases. Let me thank up front the SIK2 team at Nimbus, led by Nilo Kaila and Leon Collis. They did all the work. I get to present it, and I think it's a great story. A couple slides on what Nimbus is. Nimbus is a private biotech that has been focused on, founded around computational chemistry as a discovery engine. Started over 17 years ago, evolved over the years with the goal of making small molecule breakthrough medicines. We reach across three major areas: immunology, metabolism, and oncology. The selection of targets with a high degree of validation, where we think that a small molecule with certain properties can make a large difference for patients, is our focus. And we've always had that focus, and it's about making best-in-class molecules that will have a difference for patients. And that's where our focus has been. And just a little bit more about where we have come from. We've had several agents enter the clinic. One of our first was an ACC inhibitor for NASH, which is now called MASH, years ago. And that was partnered with Gilead, has progressed into the clinic. Our TYK2 inhibitor progressed through phase 2 with us, has now completed phase 3 and reported out by Takeda, who is pursuing that agent towards an NDA. And we're very proud of that program. Dennis mentioned some of these other programs, HPK1 and an immuno-oncology agent that showed activity in the clinic that we have not progressed. And then more recently, you might say the final three you see here are where we are today. And we're seeking to have 3 first-in-human in 3 years. WRN is in the clinic. We have completed phase 1 dose escalation. The WRN inhibitor is targeting, as patient selection, MSI-high tumors. And this is a safe compound. We're now getting efficacy data in dose expansion. And we think by the end of this year, we'll have a very good sense of the efficacy of the compound. We're very excited about the program. Today, we're going to talk about inhibitors of salt-inducible kinase type 2. We have a development candidate progressing that through IND CTA enabling studies. Next milestone is first in human for that. We also have developed an AMPK activator in collaboration with Lilly, and this is for metabolic disease. This has progressed well and is on track for a first in human. So these are our three later programs. Of course, we have an earlier pipeline, but I think you also see the breadth reaching across oncology, immunology, and metabolic disease. So that's our pipeline today. Just a word about our engine. Our engine is changing. While we've had some success, the world is changing both in terms of opportunities and greater competition, and that's great. I think it's going to lead to more agents of value progressing into the clinic. But as we think about how we change, we are expanding our target universe because what was previously not tractable looks like it can be. And so we think about that. We've had success with a more broader set of targets, things like integral membrane proteins, which 10 years ago you would not approach with computational chemistry. We can certainly do that today and have had success. When we look at our chemistry toolbox of modalities, we started as small molecule non-covalence, and we have expanded a lot here. We think this is the future for any small molecule group. You see the first acronym there, BRO5. That is beyond rule of five, very active area, whether it's peptidic molecules or cyclic macrolides. We certainly work in the area of covalence, glues, degraders, and heterobifunctionals. There's a lot there, but we think this is an approach that even a small company can take on, and it's the right approach to have a lot of capabilities, the right capabilities today with the new targets available. And then this is all combined with a physics-based computational chemistry approach and AI. And that's shown on the right, where the bottom part in blue is what everyone does. It is DMTA, in vitro and in vivo testing. I do not wish to in any way make this a smaller part of the effort as you go forward. You've got to have a high degree of expertise across the board in your DMTA, structural biology, biochemistry, cell biology, et cetera, to have any chance of success. That's also combined, though, with computational chemistry and AI for predictions, and a lot of groups, of course, have moved into this area. We have both evolving computational chemistry and increasing AI for ideation, filtering, generative design, as ways to accelerate the DMTA. And we have certain areas we've had a lot of success, and that really adds to our programs. And those components of in silico certainly did contribute to the success of SIK2, which I'll talk about now. But that's the Nimbus platform as we describe it. So salt-inducible kinase type 2, as a way, inhibiting it as a way to modulate and restore immune system homeostasis. We think this is an interesting and highly valuable target. It's been a tough one to drug. Before I get into it, I can tell you there's been multiple companies that have worked on it, and we really appreciate the success of the past from Galapagos and Janssen, who have made real inroads in this. We are proceeding into the clinic with what we think are good molecules for autoimmune disease. And we do certainly give credit to the previous groups. So the salt-inducible kinases are downstream. They're intracellular kinases that receive pathogenic and damage signals that can be upregulated in diseases through a variety of receptors. They receive those signals, and the kinase activity will phosphorylate HDACs and CRTC3s. In the cytosol, those move to the nucleus and drive different transcriptional programs. If you inhibit SIK2 specifically, what you observe generally is a suppression of pro-inflammatory cytokines and chemokines, and that is a broad effect. And you also see promotion of tissue repair and resolution. That's a very interesting and what we think is valuable set of pharmacology profiles. We think it leads to therapeutic potential for SIK2 inhibitors in inflammation and damage that occur both in mucosa and joints. And we target first inflammatory bowel disease, and rheumatoid arthritis. And I will go through some of the data that we have preclinically that supports that. So there are 3 SIK isoforms, SIK1, 2, and 3. And we believe the one that's going to give that profile that I described, that dual profile, is SIK2 specifically. So this is getting back to our engine, and I mentioned that you can't get anywhere without really outstanding in vitro and in vivo. We developed the first high-resolution structures of SIK2, so a challenging one, but we will get a very high resolution. It was essential for our success. And we were then able to implement our computational chemistry approach, physics-based free energy perturbation, which, when it is successful, is going to give you accurate predictions of potency on target, in this case on SIK2. And this is the data of predictions to real data. It's a pretty good correlation that allowed us to move more quickly to optimize and characterize potency. Certainly, we wanted selectivity of SIK2 over SIK1 and 3. You don't optimize for selectivity, you optimize potencies. So we've done this for SIK1, 2, and 3. It's all done at the level of affinity. But this was a major part of the program, was achieving very high levels of selectivity. You'll see as I talk about development candidates, we took them into, as others do with orthosteric kinase inhibitors, large panels of kinases, and we see they are highly selective, very high degree of selectivity in a kinome panel. We optimized, of course, other properties to get the DC, and that's where AI certainly helped us. Anything in the ADMET field, we've worked to fit that into models where you can apply AI and had pretty good success in terms of predictions. And that only sped up our ability to optimize physical properties of these orthosteric kinase inhibitors and their ADMET properties, which are very good in the development candidate. So we will come on to this, but I do want to say clearly we believe that selectivity of SIK2 over SIK1 and 3 is critical for both efficacy and safety. I mentioned this dual MOA that we see with SIK2 inhibition only of anti-inflammatory and pro-tissue resolution. You can get that from inhibition of SIK2 only. SIK1, there are known cardiotox risks, both in the literature and from our own data. When we had SIK2 inhibitors that had some SIK1 activity, we saw the cardiotox. We had to fully dial that out to a very high degree to have no cardiotox issues in our compounds. With regard to SIK3, the knockout mice and loss of function show bone growth defects, and they do result in fertility defects. So we did make the decision that, one, we didn't need SIK3 for pharmacology, and two, that it could create safety risks if we had a SIK2/3 inhibitor. So we wanted very high selectivity, and that was the goal of the program. We have declared a development candidate for our SIK2 program. It's in IND-enabling studies. Our next milestone is first in human. The compound has very good potency biochemically. It's ATP competitive, very potent in cells, and very high selectivity. I say here greater than 300-fold. It's great. It's in the range of 300 to 3,000-fold against SIK1 and SIK3. Very minimal hits across the kinome, so very clean. The advent is excellent. It is supportive in the clinic of QD or BID dosing. Our predicted human doses are well below 100 milligrams, and that puts us, I think, in a strong position as we are now in preclinical development. As I'll show you, we have a package of robust in vivo PD and efficacy data. So that's an overall description of our DC. As I start to go through the data, I'm probably showing mostly tool compounds, but that profile that I show you of tool compounds is very selective SIK2 inhibitors and is very much like the candidate drug. So there is some talk in the field right now about SIK2 versus SIK3, and our colleagues at Onco3R are pursuing SIK3 inhibitors. And so we feel the need, and we're doing this at posters at multiple conferences now, to share our data and what we've learned about the isoforms. This is a sort of a non-scientific summary of a lot of data. I'll go on to show you some of that data. When we look at that anti-inflammatory profile, which with SIK2 is broad, we see that full profile purely by inhibiting SIK2. If you go to SIK1 and only inhibit that, you see very little of that profile with a SIK1 knockdown or inhibitors. You don't get the anti-inflammatory. You get some of it with the Galapagos onco3R compounds, and some of that I'm sure is due to SIK3 inhibition. Some of it might be due to the fact that those compounds are not that selective. So we don't know. There might be a contribution from SIK2, but it does not reproduce that broad anti-inflammatory profile. You get that from SIK2 inhibition only. That pro-tissue repair profile, which is the hallmark of it, is an increase in IL-10. Get that fully with SIK2. You see none of it with SIK1, none of it with SIK3 inhibition. Again, pointing to SIK2 as the right target for the pharmacology. And as I mentioned, we have SIK2 inhibitors that certainly the knockout mice are viable, but we see good safety margins with pure SIK2 inhibitors. And that's why we've progressed beyond DC into preclinical dev. With SIK1, as I mentioned, you see cardiotox, and there's publications on this, and that was our own experience. And then the SIK3 really comes from publications, mostly knockdowns that point to bone growth defects and potentially fertility defects. So I go through this in some detail so that Nimbus can add to the ongoing scientific discussion. We think the right target here for clinical indications like IBD and RA is SIK2 inhibitors. So this is a summary. I'll show the data as we go. Now, as I get into some of the data, excuse me, I'll go through SIK2 inhibitor data and compare it in some cases to SIK3 selective inhibitors, other cases compare it to the JAK inhibitor, upadacitinib, and other cases we'll compare it to murine anti-TNF. So relevant to compare it to the isoform, but also agents that are relevant in the clinic or are standard of care. So here we're looking at a comparison of SIK2 selective versus SIK3 selective inhibitors. Both result in TNF alpha decreases under cases with human macrophages where you've stimulated with LPS and interferon gamma. But then as we look at IL-23 and IL-12 on the right, you can see that the SIK2 inhibitor, actually it's difficult to see, but you get a full suppression of IL-23. And what's interesting is that if you inhibit with a SIK3 selective inhibitor, you actually increase IL-12 and IL-23. So we would say that is a detrimental attribute of inhibiting SIK3. If you want the full inflammatory, anti-inflammatory profile, SIK2 certainly appears to be the better profile, the better target. Here we're comparing to a standard of care in rheumatoid arthritis, the JAK inhibitor, upadacitinib. Anytime we're using upadacitinib, certainly in vivo, we use concentrations that we have calculated as best we can as equivalent to what's used in human doses. So as we again go back and a similar system here, stimulating macrophages, human macrophages with LPS, again, that full suppression of TNF alpha with SIK2 inhibitor, UPA, results in an increase in TNF alpha. Others have reported this. So this is an approved agent, but it actually increases TNF alpha. And as you go through the rest of the data, you see this decrease in IL-23 by the Nimbus compound, but that JAK increases IL-23. The SIK2 inhibitor promotes IL-10, that tissue repair, promotion, cytokine, and JAK inhibitor does not. UPA does not do that. So as a head-to-head comparison, certainly the SIK2 profile looks better. This is now diving in, again in macrophages, going to a full RNA-seq. So if you treat LPS-stimulated human macrophages if you treat them with a SIK2 selective inhibitor, and you look broadly by RNA-seq, what do you see? And the profile, I think, is quite telling. You see a whole set of tissue repair genes that are increased and a whole set of pro-inflammatory genes that are decreased. I think this is quite convincing when you look globally to have a very good sense of the profile of pure SIK2 inhibition, and we think that looks quite attractive. Certainly, we've done the agnostic gene set enrichment, and what comes up are is that you have upregulated genes enriched in pathways that support tissue repair. So as you look at these human macrophages, that's consistent with what I said earlier about that dual MOA, anti-inflammatory plus tissue repair. Continuing that, moving from genes now to proteins. And here we're looking at some specific markers of tissue repair at the protein level. Certainly one of the important ones is amphoregulin, an EGFR ligand, and a tissue repair factor increases with SIK2 inhibitor in a dose-dependent manner in orange. Upadacitinib does not. And that's shown on the right now, comparing it to the SIK3 inhibitor. Big increase in amphoregulin and an increase in thrombospondin with SIK2 inhibitor and not with SIK3. More data now at the protein level of this pro-tissue repair pharmacology only associated with a SIK2 selective inhibitor. Continuing in the same theme, now moving into the in vivo system. Now we're in mice treating with both SIK2 and SIK3, and this is consistent. Upregulation now in mice with the IL-10 with SIK2, and you do not see it with SIK3. Really just building on the data to show that it's not in a single system. In fact, we've done this in many systems. I'm showing some of them at a translational level. We did this in many, many systems, both human, ex vivo, and in mice and murine systems. And then another slide, finally, in vivo, that summarizes a lot of data showing a dose titration of TNF with SIK2 inhibitor, but also showing all of the pro-inflammatory cytokines and a few chemokines that are decreased with SIK2, the chemokines being MCP1 and MIP2. So that is a broad profile, and then that increase in IL-10 in vivo that is dose dependent. And this really helps us as we make plans for the clinic, that we see this dose titration. So moving into efficacy studies, I will tell you that in terms of Nimbus pharmacology, we probably put more weight on the PD studies that I showed. Everyone, I think, who works in this area realizes there's limitations to the efficacy models, but we still ran them and we saw good activity. For models for ulcerative colitis, we ran the anti-CD40 and the DSS model. We had full activity with a SIK2 inhibitor here in the anti-CD40, and you can see it with the stool score, 100%, well, a full effect, I will say. I realize there's noise in the data, but really a full effect, both with the SIK2 inhibitor and the anti-TNF. That is a full effect. On the right, the DSS model, we see a robust effect. It may appear maybe that the SIK2 inhibitor shows more activity than UPA at a clinically relevant dose. I'm not sure that difference is real. I will simply say that we're seeing quite robust activity with a SIK2 inhibitor in the DSS colitis model, measuring that cumulative disease activity score. So really nice activity in both these models. And people may ask later, we've done it both in a prophylactic and a therapeutic manner, and we've seen good activity. So I mentioned multiple times that there'd be a pro-tissue repair effect. And so, of course, we looked at that in the DSS model. And the functional way to do that is to use a fluorophore, fitsidextran, and look at its leakage through the gut into serum. And it's a standard assay. And you can see as you look on the left, as you go to treatment with DSS, shown by vehicle, you see this big increase in fitsidextran getting into serum. And that's because of the loss of gut barrier integrity. If at the same time you're treating with a SIK2 inhibitor, you diminish that more than 80%. So you really have improved gut barrier integrity in a functional assay. And you see something similar with a JAK inhibitor. Maybe not quite at the same level, but I think both show a restoration of gut barrier integrity, really important marker as you think about developing any new agent for ulcerative colitis. There's also, clinicians are also using important markers of mucosal healing, and they will look for these in patients. So we certainly looked at them preclinically, both mucin and occludin. And you can see both of those go down a lot when you treat with DSS, and that's shown by vehicle. you see they are restored to a high level, mucin and occludin, when you treat with SIK2, really strong markers that we are promoting mucosal healing with a SIK2 inhibitor. You don't see that, or you see it to a lesser degree with upadacitinib. So together, telling a story that we are promoting mucosal healing in the gut of a relevant UC model. So again, we're going to return to gene expression. Now it's going to be done in vivo to confirm a little bit further of where we are. And what we're showing here is, I take you through this on the left. It requires a little bit of an explanation. We're looking at a set of thousands of genes all the way on the right under normal, under lower to higher expressed. Those same genes are shown on the all the way to the left where it says vehicle, and they flipped. So there's a whole set of genes that when you treat with DSS have a differential expression. Of course, you would expect that in the disease model. So what happens if you had treated with a JAK inhibitor? What you see is they look mostly like DSS. There are some changes, but it looks more like DSS at a global level. If you look at SIK2, it has returned it mostly to look more like normal. So at the global gene expression level, a SIK2 inhibitor seems to restore it back to what appears to be more closely resembling normal. And again, that's at a global level. If you then do gene set enrichment from these in vivo samples, and that's shown on the right, the same pattern comes up. Up regulation, tissue repair, down regulation, and inflammation. So confirming what we've seen in those human macrophages, we do see it in vivo here. So that is a summary of a lot of data on the use, potential utility of a SIK2 inhibitor in UC. We did similar set of work to look at a SIK2 selective inhibitor in rheumatoid arthritis models at a preclinical level. For the sake of time, I'm not going to go through this. I'm only going to summarize what is a lot of data and refer to these 4 blue squares shown here. So what's the profile we see for the SIK2 inhibitor? We see a reduction in inflammatory cytokines like we did in the gut, and chemokines, all implicated in RA pathology. So if you look to the right in that figure, it shows that this whole set of cytokines, chemokines, and growth factors are all decreasing anywhere from 55 to 90%. Robust knockdown in all of those. What's very important is the top 3, TNF alpha, IL-6, and IL-1 beta, are all clinically validated with biologics. These are all used for RA. They've been clinically validated. And here we're able to get a knockdown of all 3 with a single oral agent. You'll also see that the inflammatory chemokines are decreased, and that's going to lead to a decrease in the recruitment of inflammatory cells. So that's going to be a real benefit in the synovium with the treatment of a SIK2 inhibitor. We did go into the standard efficacy model, the mouse CIA model, and we saw activity equivalent, efficacy equivalent to upadacitinib again, and that is a nice finding that we see efficacy there. The other finding, and we have this in our poster, we do see a decrease in osteoclast differentiation across multiple SIK2 inhibitors. That's going to be an indication that there's going to be a reduction in structural damage in the joint upon treatment with a SIK2 inhibitor. We think overall that profile looks quite attractive for SIK2 in RA. So, we certainly have a priority of taking our agent forward into IBD, but also a strong interest in moving forward in RA. We think that's a favorable profile. Just briefly here, when we think about moving into the clinic and our proof of mechanism in those phase 1, phase 1b studies, some of the readouts we're looking at, they're all going to be based on these cytokines and chemokines. We're going to be looking systemically. We may be getting samples in the colon, for example. We will run a peripheral ex vivo stimulation, but overall, we're looking to profile PD in the colon, first in the colon, ultimately maybe in synovium, with these sort of markers. We think these are the ones that will allow us to get a sense of the relationship between blood level and on-target effect. And so these become very important going forward. So I'm going to stop there and just summarize. If I take a step back and say a word about our SIK2 program, with the goal of first going into IBD, it's first worth mentioning what the need is. Treatments are not good enough. Really, only today, fewer than 1 in 3 patients with IBD achieve remission in 1 year. There's a lot of room for improvement. It is worth saying that this year, there have been some great phase 3 results that have come forward. People are excited about combinations, but there's a lot of work to do and a need for additional agents with different mechanisms. So we think the unmet medical need is still there and it's quite high. We've shown, and then we showed you some of the data that that our SIK2 selective inhibitor compares favorably both to anti-TNF and JAK inhibitors. And we think that dual MOA, which I talked about, is going to be quite valuable in IBD and in RA. The other thing that's worth saying a word about is that broad anti-inflammatory profile. There was completed, I think, last year and reported the phase 2 Vega trial by J&J, and they've gone to combinations of biologics. And they found that when they combine, so anti-TNF and anti-IL-23 are already valuable treatments for ulcerative colitis. But they found when they combined them, they saw almost an additive result in 12-week clinical remission. It is a big step forward for patients going from 25 to 47% clinical remission. It's really, I think, pointing the way. I think the field's going to go in the direction of combinations. What we're saying is that this profile looks like a SIK2 inhibitor will result in a suppression of both of those with a single oral agent. So we think that's exciting. And I'll just mention as I finish, where is our program? We've declared a development candidate, which we're quite excited about. That is moving through preclinical development, and our next milestone is a first in human, and we are excited to move that forward and see where that program goes. So with that, I will stop. Let me acknowledge what is a fantastic team that has been led by Leon Collis, the biology leader, and Nilu Kaila, the chemistry leader. That team has really done an amazing job. It's a challenging program to develop safe orthosteric kinase inhibitor for an I&I indication. I think they did a fantastic job, so I want to make sure I give them all the credit for what was a great job. I will stop there and very happy to take questions.
Awesome. Thank you so much, Peter, for this really data-rich talk. I think this was really educational for people. And it seems like we have a lot of questions in the audience already. It seems like a lot of people who are working in the field have been listening. So those are some of those questions will be expert questions.
Yes.
So
that'll be fun.
Awesome. Yeah, let's start with David Winkler here. So David Winkler is wondering, do you believe that the bone anabolic effects are completely lost with the SIK2 selective inhibitor?
There's two parts to that. There's complexity to that question. We are interested in whether there are bone anabolic effects on osteoclasts in the setting of RA. I would say those studies are ongoing. In a setting outside of RA, we have not seen bone growth effects. Maybe I will leave that there and say that in the setting of RA, we continue to explore that. He is probably aware of the complexity of the various cell types, and that is going to require more work to work through that.
Absolutely. In the same vein, another question on the osteoclast. So an attendee asks, on slide 19, you mentioned that the SIK inhibitor decreases osteoclast differentiation, but you mentioned earlier that you do not expect side effects on bone homeostasis. Maybe could you elaborate on this a little bit?
Yeah, I don't have a simple answer for that. We see it in that setting. We certainly are going to be careful about talking about safety studies. I'm gonna pause on the safety question, other than to say that to this point, we do not believe there's a safety issue, and I think people recognize you're at a DC stage and we're in the middle of other studies. But I realize that's an incomplete answer, but that's as much as we can say right now.
Awesome. Yeah. Another question is about what is your mechanistic explanation for why SIK3 inhibition would lead to an IL-23 and an IL-12 increase?
Yeah, I don't have an answer for that. I would love some of our basic science colleagues to work with us on that. I will
Yeah.
say that I think I can reveal that we've had an ongoing collaboration with Mark Wine, who's an excellent pharmacologist at Harvard, and we are working through questions of SIK2 and SIK3 pharmacology. As yet, I don't have an answer for that one, but except to say that we remain interested in understanding further SIK2 and SIK3 pharmacology.
Yeah, totally. David Winkler also wonders, is there an effect on TGF beta as well?
That's a great question. I don't know.
Okay,
But David, I'm happy to get back to you. I'm sure Leon Collis has the answer, and I can follow up on that. Leon's our head biologist.
awesome. Sounds good. Earth is wondering about, is there any info on brain expression of SIK2? And is there any potential for SIK2 inhibitors in CNS indications?
There might be. Our agent does not have brain penetration. And, you know, so there's studies on SIK2 in the CNS. There's probably 200 papers on the role of SIK2 in a variety of diseases. I'd say there's complexity around that we don't understand. Is there a potential for the value of a SIK2 inhibitor in various CNS indications? Yes. I don't think there's enough studies around that yet. I wouldn't say there's enough validation around it.
Sounds good. Earlier, I think you mentioned there are some limitations in those, I think ulcerative colitis models. Could you elaborate a little bit on the limitations of those models?
Yeah, so our GI people online, the biologists who have worked in UC, know this better than I do, but am fully aware that those UC models are not overly predictive. The activity, so first off, if you look, the intra-experiment variation is large, and it becomes, because of that variation, it becomes a little bit more qualitative of whether you see activity or not. And so, we reached a point where I showed you data where one could have concluded that SIK2 is better than JAK. I don't believe it. I think because there's variation in the data. Moreover, the predictive power of DSS or anti-CD40 for activity in the clinic is poor. So how does one proceed? The way we proceed is by having as much data supportive of a PD effect that we know is relevant. We know the TNF and the IL-23 are relevant. To us, that's more valuable. Efficacy has not been predictive.
Yeah. It makes total sense. And I've heard similar answers in the pain field as well. People are moving away from animal models and
Yeah.
are moving much more to target engagement and PD effects. So yeah.
Yeah, there's a place for using human samples, certainly cultured human cells, but actually direct human primary samples. We've done some work in that area, at least at the level of showing PD effects. And those, I think, are absolutely, they play a critical part in the degree of confidence you would have in whether you would see activity in the clinic.
That's good. Yeah. Another question is about the anti-CD40 model. People are wondering why this has been used, given that it's lacking adaptive immune cells and only captures myeloid compartment effects.
Yeah, I mean, myeloid is going to be important for the mechanism that we are pursuing. SIK2 is a myeloid specific target, so you can argue that it's imperfect. Absolutely, any of these models are imperfect. My understanding is that any model is going to be specific to the particular stimulus and cell type that is driving it, and so I don't know that there's no ideal models for that. But I take the point that it is limited. They all are.
Yeah, makes sense. Yeah, and then I have a personal question, I guess, about the selectivity. I was like fascinated. You talked about a 300-fold to 3,000-fold window over SIK3 and SIK1, and you mentioned that the compound is an orthosteric inhibitor. Given that there's high sequence homology, especially in the orthosteric domain among those salt-inducible kinases, I was wondering, did the team look at molecular dynamics, or how did the team think about achieving selectivity in such a super complex setting that's even more complex than achieving selectivity in JAK inhibitors, which already is a big challenge in the industry. But I'm just,
Yeah.
stunned by the results.
Um, this is a tough problem. If you look at the active site and just do between SIK1, 2, and 3, and look at the identity, it is almost identical across all three sites. The differences are minor. And we went as far as, I think, to find selectivity based on cases where the amino acid on the surface of the active site where we had an interaction was the same. The difference was further away from the active site that gave us an opportunity to build in selectivity. So it was subtle differences that we worked very hard. Was it driven by molecular dynamics? Yes, absolutely needed an FEP approach to identify some of that side by side with a lot of very good med chem.
Amazing. Amazing.
Yeah, it was a tough problem, and I will say too, because I might have said it, but I want to repeat it, that our assessment once we were well into this program is, and we heard this from others, the big issue was safety. That there was questions of whether you could ever get a safe compound. We think we have a safe compound as far as we've made it so far. And we found that what we needed was more selectivity. There's a reason we've got greater than 300-fold. We got into the 1,000-fold range in many cases. We think that's essential for that right safety profile.
Super exciting. For those kind of non-biologists in the audience, could you elaborate a little bit more about the IL-10 effect on the tissue repair? I mean, you've shown that very nice effect with reducing IL-23, and those are definitely some of the hot mechanisms with icotokinin recently approved from J&J. Could you maybe talk a little bit more about this IL-10 effect and how people have been thinking about this in the industry?
Yeah, I'll simply say that IL-10 is quite clearly involved upstream of promoting tissue repair, and the basic science showing that is fine, is quite solid for a variety of mechanisms, right? It's not a single mechanism. And when people have pursued treating with IL-10, it hasn't worked for a pro-tissue repair effect. And the explanation might be that it needs to be intracellular, it needs to be in the right cell type, it needs to be in macrophages. I don't think we've worked that out. I would say seeing IL-10 only is not sufficient to say you're going to have a pro-tissue repair. Hence, all the work I showed regarding the larger profiles and then the functional effects. It's an important marker, but you certainly need more data. It's very much upstream of these tissue repair pathways.
Yeah, super cool. Yeah, I'm trying to understand more about this myself too.
Yeah.
Sounds good. I guess we have maybe one or two more questions here. One is about an AAI poster that Nimbus showed, and it says you show potency and selectivity of the inhibitor, and the SIK2 compound inhibits SIK2 equally as well as SIK3. Why is there no similar effects on IL-23 then? Not sure if I
Ah,
understand the question, but you might have you might have a
he's
better
the
understanding.
person is referring to data I didn't show. It's in the poster. It's interesting. We have SIK2, we have a SIK2/3 inhibitor shown. I actually switched to make it more clear. I said, can we show our data on SIK3 and SIK2? Um,
Got
I
it.
think you're getting into it. So, all I will say is there's a complexity there if you're hitting both enzymes.
Yeah.
One is decreasing IL-23, one is increasing. I like for the cleaner experiments, the data I showed, which is those selective inhibitors. We certainly have that data. So if AAI poster was not sufficiently clear, hopefully the data I showed clarified it.
Awesome. And then, yeah, I guess maybe another person has a question on this effect of SIK3 on fertility. Is there
Yeah.
anything you can
No, I
share?
don't know if I know the specifics.
Yeah.
I don't have an answer for that.
Yeah. No
Other than
worries.
that's what's seen from the data from the
Yeah.
knockouts. Yeah.
No worries. Cool. I think we have a general question beyond SIK2. So As we all know, many AI models are evolving to predict the ADME and toxicity properties of molecules. In your opinion, to what extent do these predictions reliably translate into in vivo outcomes? And where do you see the greatest impacts of the AI models? This is a question from Srini Kara.
Yeah, Srini, I'm going to refer to some of the things that the head of CompChem at Nimbus has said. His name is Dan Price. Is that we start with skepticism, that we do not ascribe to some of these, what I'll call grand claims that AI is revolutionizing all of drug discovery. I think those of us who are doing this every day take it as individual experiments to look for the improvements. And places where we've seen a lot of improvement is ADMET predictions. And so we think that's really useful. Physical properties, Dennis and I just talked about that a little bit. I think what comes next is not toxicity. I think that is too ambitious. But I think you can do it step by step. We certainly are looking at DILI, for example, where there's strong in vitro and in vivo data where predictions may be more useful. I think it's going to go this way. AI can't pull something out where individual scientists can't. So you're really going to have to move it step by step. And then I think it could be quite powerful, side by side with very good scientists.
Yeah, I love that answer. Yeah, and to the DILI predictions, I've been fascinated by those organ on the chip models
Yeah,
that are coming out recently. It's like oftentimes animal models are not predictive of DILI, so there's actually
yeah,
a lot of DILI effects that are not predicted in animal models, but that I think a recent organ on a chip, a liver on a chip in this case, model has predicted. So really excited to see the developments in that case.
yes, yes. I
Yeah.
think over the next 5 years, we'll see a lot of progress there.
Yeah, yeah, and yeah, with AI, hopefully as well. So, Peter, this was amazing. Again, thank you so
Great.
much for a great talk and sticking around. We still have questions come in, but unfortunately, we're running out of time. So, yeah, thank you again for a phenomenal talk.
Great. Dennis, thank you. I enjoyed it a lot. It was really good.
Amazing. Yeah. And thank you to our engaged audience for all these deeply scientific questions. I learned a lot today, I have to say. And Peter taught us a lot about the biology today here and the data coming from this very cool and selective inhibitor. I'm super excited for the mechanism and to see more data coming out of Nimbus.
Wonderful.
Yeah, we will be back here in May, on May 14th, talking to Richmond Sarpong. He's a professor at Berkeley, and he'll be talking about skeletal editing methods inspired by natural product synthesis. So we'll see you guys then. All right. Bye, everyone.
Thanks.
Take care. Bye, Peter.
Bye.